Hello and welcome to the Providence College Podcast. I'm your host, Liz Kay, and I'm joined by producer Chris Judge of the class of 2005. Here at the Providence College Podcast, we bring you interesting stories from the Fryer family. Today, we're talking with Jillian Rose of the class of 2004. Jillian is Director of Community Engagement, Diversity, and Research at the Hospital for Special Surgery in Manhattan, which specializes in orthopedic surgery as well as rheumatology. She was recently awarded the Distinguished Educator Award by the Association of Rheumatology Health Professionals. Jillian, congratulations on your award, and thank you so much for joining us.
Thank you so much for having me, Liz, and thank you for the kudos. I appreciate it.
Could you start by telling us a little bit about what inspired you to pursue a career in health education?
I started out at Providence in 2000 and graduated in 2004. However, my interest in public health started when I was in Guyana. I was born in Guyana, which is in South America. It's the only English-speaking country in South America and a very impoverished country. And I migrated from Guyana when I was 11 years old, but had the chance to see in a very firsthand way the broken healthcare system and the inability of people to really secure health and healthcare and live safe and healthy lives. So they were high infant mortality rates, and high mortality rates basically around things as basic as common cold or a person getting a cut and it not being treated well and becoming sepsis, and subsequently them having an infection that would lead to their death. So being around that type of environment really inspired me to pursue a career in looking at how do I best educate people about their own health and how do I help to motivate others in negotiating healthcare system.
You majored in both social work and health policy and management here at PC. I'm curious how your PC education impacted your career here.
Absolutely. I stumbled into social work. I wanted to be a dentist. So I came in pre-med, and I wanted to be a dentist to make older people smile, and that was my thing. And then I had chemistry, and said, "Nah, this is not going to work out too well for me. I don't like kind of being in the lab and figuring these types of things out. I don't like kind of the rigorous kind of science pieces. I really like science and research that's more applied." And so I was kind of bored with that work, and then having the experience of having to dissect the frogs and pigs really wasn't up my alley. And so I decided that public health was something that I would move forward with, and had Professor Hackey at the time. I'm not sure if he's still there.
He definitely is. He definitely is.
Awesome. So, and then I stumbled into a social work class. I don't know how it got on my schedule, and I'm forgetting the professor's name at this time, but she was from New York. And would go back and forth, but her class was really looking at the workings of social work theory and practical practice, and looking at human and environment and the whole ecological model of how when a person is provided care in a healthcare setting, and when they go back into their own neighborhoods, how does their neighborhood and where they live, work, and play, what we call social determinants of health today, how that impacts their lives, and how social workers really can help to empower patients, people, clients, in terms of moving forward with securing the things that they need for their lives to secure their health. So I stumbled in on that class, and I kind of went into unregister from the class because I don't know how it got on my schedule. Sat in the class and was like, oh, this is right up my alley. This really helps me to understand human behavior. This really helps me to understand the dynamics of where people live and work and how it impacts on their decision making, things like resources and things like that. At the time, we weren't calling it health disparities as we do now, but essentially that's what the class was really about, and how social workers can impact change by understanding various theories that has to do with individual behavior and behavior change. And so I decided to double major in health policy and management and social work.
That's amazing. So it sounds like the happiest accident. You went into to unenroll.
I would also credit my time there in terms of my own learning to Dr. Jackson. He taught our philosophy classes and really talked about the human state and the human condition from a historical perspective. I mean, 2 years of Western civilization, I thought I would hate it, but it really informs the way I interact with others and understand the world, even in my practice today. And then the head of the department at the time, I think her first name was Marion, and I'm forgetting her last name. I'm really bad at this today.
But in philosophy. In
social work, the head of the Department of Social Work at the time, she always talk about, walking side by each with your client and being in their shoes. And she was the real catalyst for me kind of looking up and out to attend Columbia. She was also a Columbia alum. And I remember in my junior year, she was just like, this is what you're going to do. And these are the changes that you're able to make in the world if you pursue this career path. And she was just a very strong and inspirational woman, leader of the social work department at the time, as well as a real influencer for change in her own right, in her own work, in her own research, and in the running of the social work program at that time. Marion Madison.
Madison, yes. I've heard a lot of alums talk favorably about how she's impacted their careers. But looking at your resume, it seems like you followed her recommendation and then never left grad school after that. Can you tell us about your myriad degrees that you received? I mean, so you started out with your master's in social work from Columbia. Where'd you go from there?
So I started out with my master's in social work, and then I went on to achieve my public health degree at Johns Hopkins University. And then now I'm back at Columbia again. But I have to tell you this. I think there's one thing that Providence taught me as a Black woman coming onto a campus that was homogenously white. It was absolutely intimidating to be there. I grew up in Hartford. I went to an all-Black school, and my counselor, she said to me, my school counselor, she said, apply to Providence College. It's a great place. It's not as diverse, but you will get a quality education, right? And so I couldn't imagine how homogenously white the campus would be when I got there. So it was definitely an adjustment. And so I wanted to also be a part of social change. That's why I joined the club and was a part of the Balfour Center with Walesi Kamajan, who looked and worked in multicultural studies and really provided a home for the college experience of inner city kids coming into a school like Providence, and really provided a cradle and helped us get through the college experience. The institution was also embracing of the learning and the changes and the transformation that needed to happen for more minority students to feel more embraced. And I feel very proud of those conversations and the evolution of that, because as I was there, I saw the change of, the influx of more and more students of color and more diverse students, not just students of color, but students from many different backgrounds and religions and culture that really made our campus experience even more rich. And so I do have to commend the institution for the evolution, even in my time, that they embraced.
That's wonderful. I'm glad to hear that. I mean, you knew coming into it that it would not be like your high school, but you were able to find a home and a place and succeed phenomenally.
Absolutely. And there were teachers there were professors who were just about learning. There were professors who were just really passionate, like Dr. Madison and Dr. Hayes and Dr. Jackson, who was very focused on helping us to meet the challenges of life academically as well as personally. So they were invested did. And that's one of the other things that PC has going for it. They had professors who were very smart, brilliant people, like Dr. Dadier, who I did my student internship with, my student work study with, although I wasn't a part of that program. Dr. Dadier's work and his studies, he kind of took me under his wings and really helped me to move through the college experience. But people were really invested in helping students to learn and kind of move through the next phase of their lives.
That's wonderful. That's really wonderful to hear. And as you said, you were really inspired to provide outreach for patients, for minority patients and other patients. And this most recent award really recognizes that work you've done to rectify inequalities of care. I'm curious if you could tell us about some of the things you've done to help patients, particularly women of color, in some of the work and fields that you've done.
Absolutely. At Providence College, I had an internship too at the Met School. And it was, the Met School took a different approach to learning, and it was really in the heart of a community that was disproportionately affected by everything. It was an impoverished community. And one of the things that I had as a project was to help to create a school-based health center, and really interacting and engaging with students who didn't have appropriate health care, or didn't have food to eat, or didn't have school lunch, or, just didn't have the resources at home to kind of move through the things that they needed to move through, as well as who would have to go to appointments with parents who English was a second language for them, and really have these like Maslow hierarchy of needs that they had to meet as students for their immigrant families before they can even think about their own education. And so having that experience at Providence College and moving towards a degree at Columbia, my social work degree at Columbia, that experience in Providence really helped to inform me about the person and environment and looking at patient care and what that meant. So it wasn't only about seeing the doctor. It was about understanding your illness. It was about looking at your cultural values and beliefs. And it was also about looking at the resources that you had when you left the doctor's appointment after that 15 minutes encounter. Who was your interpreter? How would you get your medications? Did you have copay? And so having gone to Providence College and done social work, I was able to inform the needs of my client from that perspective and come in with a very rich basis of looking at healthcare and the healthcare experience of minority people. And so my first job at Hospital for Special Surgery was being a supervisor of lupus support and education programs. Lupus is a chronic illness that disproportionately affects women in 9-to-1 versus men, and especially women of color. And it affects African American, Asians, Latino women, and Asian women 4 times more than it affects white women. And we don't know why. And it's an illness that can be very debilitating. It's a chronic illness, and you have it for the rest of your life. It's also an illness that's very invisible. So people think you're well and you're okay, and you can be well and okay today, but tomorrow you could be, unable to wake up and comb your hair or dress yourself or cook for yourself or take care of your children. And so the illness can wax and wane in that way very quickly. So the expertise of being able to understand where a person is in their life, their resources in their home, and what that means to them in terms of dealing with a chronic illness, as well as understanding their resources, helped me to build programs that would empower the patient beyond the exam room.
Can you tell us a little bit about more of those programs?
Yeah, so the 2 of the programs that I first started managing was the Charla de Lupus Chat program, and it was a support and education program for people with lupus and their families, and we provide individual support and counseling to patients in our waiting rooms and in our doctor's office to look at their psychosocial needs. and what barriers they have to care and help to bridge those gaps. We have a support and education group for teens, young adults, and their families to help them to better understand the management of lupus and what living with the disease is like. We provide outreach to our community in the form of health fairs and professional talks to doctors, nurses, and other clinicians across New York and across the country. And we also provide a telephone service in both English and Spanish with peer health educators who've had lupus for 10, 20, 30 years to provide on a toll-free line counseling to other people with lupus and their families. The other program we have is called Lupus Line, and it's been in existence since 1988. Again, where veteran counselors who've had lupus for 20, 30 years provide counseling and support over the phone to anyone in the world who calls the line, who is a patient or a family member of the patient, to learn about how to cope and manage their illness. And that program also, we do have medical advisors for both programs. We provide in-service training for our doctors, our fellows, our residents, our physicians in training to help them to integrate these programs into the life space of our patients. So when they go home, they're not isolated. You know, when they go home, they don't feel like, okay, I only have 10 minutes with the doctor and I don't understand. They can pick up the phone. They can call a Charlotte peer health educator to find out more about how to manage and cope with the disease, but also how to better understand what's happening with their bodies, as well as how do I talk with my family about this? How do I talk with my job about having a chronic illness that takes me away from work? You know, what types of resources are available to me and my child and my family in coping with this illness? So we provide a full service level of support to help patients to cope and manage their illness outside of the exam room, as well as a cultural perspective and what's valuable to the patient to our doctors, so they're more empathic when our patients walk into the room.
So it's really meeting the patients where they are and not trying to have them kind of, well, these are the types of steps that we think you should do. It's finding out what's valuable to them and important to them if they have hobbies or pastimes or, you know, a family that they need to do.
Absolutely. And, you know, one thing, it's humanizing to know someone's hobby and their pastime, but it's actually life-saving to know that someone is going to go to the Dominican Republic for a month after you've prescribed an infusion therapy for them for the next 3-4 weeks, and they're not going to adhere to your treatment because they don't trust you. And so we serve in the in-between spaces in the lives of our patients where we can relate to them culturally and join, you know, as best as we can their cultural value for complementary therapies, and having a conversation with our physicians, you know, in terms of the Western medicine that's also valuable to this perspective, and to find a space where that conversation can exist and to co-create a treatment plan with our patients, looking at what's valuable to them instead of them having to say, yes, doc, I'm going to do this, and never show up again. So it's really looking at patient safety issues and what's going to be right for that person to preserve their lives and to preserve the quality of life that they want to live. That's
amazing. To have that kind of interaction and knowledge and respect for the patient's life. That's really amazing. I'm curious how, you know, you've been working with lupus patients and their families for more than a decade. How have you been able to use technology to help reach them and their families?
Oh, that's it. You know, one of the things that we did, we launched about 2 years ago now, is an app called Lupus Minder, LUPUS MINDER, and it's a free app to help to manage your chronic illness. You can have rheumatoid arthritis, you can have asthma, you can have fibromyalgia, any chronic illness, any illness that you have, you can use the Lupus Minder to manage that illness. It looks at medication doses, physicians. It kind of pulls all your medical care information together in one place. You can take pictures of your symptoms, write in the app what's going on with you from day to day, monitor your mood and your symptoms, and track it over time. And this app was really created by our patients. As a social worker, when the idea to create the app came up, we said, hold on, wait a minute. We need to hear from our patients and what they really want in terms of if they're going to use the app. So if they're going to really use it to integrate the app into their lives, what do they want in it? We're not going to use it as clinicians. So we have several focus groups with our patients, as well as our adult patients, as well as our teens and young adults who are the really native user of this technology. And we built the app to their specifications. And from the feedback we learned in those focus groups that we conducted. And so we've had about 3,000 downloads so far in terms of launching the app. And we're going to look at this in terms of how people are using it and plan to do a study on how it's being integrated into the medical interactions with patients and their doctors. But we've really gotten some great feedback about the app. But all the programs that we do, all the programs that I'm involved in, it's really about the patient. If it's not patient-centered, then we're really wasting our time, because the patients are the experts about who they are, and we can't do our work if we don't engage the patient. And if we're not able to connect with the patient, we cannot share with them all this wonderful research that we're doing. We cannot share the new technologies that we have, and we certainly cannot make an impact in the public health disease states that we have, at epidemic levels, if we don't put our patients at the center.
Jillian, there's so little about the healthcare system in the United States that's patient-centered or patient-driven. This is like mind-blowing to hear you describe it this way. I wonder if you could talk a little bit about your work. I was intrigued to read about your work as the chair of the Hospital for Special Services LGBTQ plus committee, because it sounds like you're using data to try to help patients, in different situations. I wonder if you could talk a little bit about how that data helps inform some of the decisions and trainings you do at the hospital.
Absolutely. So back in 2012, there was this big conversation happening. There's been big conversations happening about health disparities, for several years now. And the IOM came out with 2 landmark reports about health disparities in minority populations, and other reports talking about how those disparities are getting deeper, and how we don't understand why minority people were disproportionately affected by so many different diseases, even when we control for insurance and access to care. And so one of the national initiatives is to better collect data to understand disparities. So, I moved into the position of really being interested in looking at how the data and demographic information we have on our population can inform our care at very granular levels. And what I mean by that is that if we don't know the population that we're serving, we cannot serve them in a more nuanced way. For example, if there's an influx of people who speak Arabic in our catchment area, in our service area, oftentimes you get that information on the back end after people start coming to your institution. However, with collecting race, ethnicity, language, sexual orientation, and gender identity data, you're able to have information so that you can trend the care of patients. So you can look to see who's coming into your institution and prepare for them with the resources that's needed. In addition to that preparation, there's the first looking at, am I serving patients who are of a different culture, of a different background, who speak a different language, of a different religion, who identify their sexual orientation and gender identity in a different way? Are we missing anything with those patients? So I've created a standardized way at the hospital for collecting the data, and really looking at the technical parts of collecting it and using best practice questions, training our staff on how to best collect it in a most respectful and dignified way, because we don't want to alienate people. Having an experience with healthcare, we know in our country, has been riddled with racism, going back to the Tuskegee Airmen, going back to a history of the LGBTQ plus community being marginalized, being abused, having violent experience, and in healthcare spaces. We want to ensure that people are not stigmatized by the question, but empowered and best understand why we're asking the question. So it was important for us to create an infrastructure that was more welcoming and embracing and inclusive, so that we can ask appropriate questions and let patients know we're asking because we care. We're asking because we want to ensure that we provide the highest quality of care to all of our patients. And it's not, we wouldn't know if we're doing that 100% unless we have appropriate data. So, for example, in our gender identity data and sexual orientation data collection spaces, we have been able to not only reach out to our patients to let them know why we're collecting and provide training, but we've also been providing training to our clinicians, our doctors, our nurses on, for example, a person who is now identifying as a transgender man should have a pregnancy test because they were biologically and probably still is biologically female. And gender identity does not predict a person's sexual behavior. So if we're going to perform surgery on someone, we need to know that they're not pregnant, whether they identify as a transgender man. And so we don't make assumptions about people that put them in unsafe situations. We need to understand as clinicians when to stop hormone therapy for a person who might be transitioning so that they wouldn't be at risk for blood clots, when they come for us to surgery. So it's important for us to understand and ask appropriate questions of different populations so that it can inform the safe care that we provide.
And this certainly isn't the first award you've received, but I remember I was reading through some of the accolades you received previously, and saw that when you say you work with clinicians, you were being praised for being willing to come in at 2 a.m. to train night shift staff. So I think when you talk about the work you're doing, it sounds like you're doing it around the clock, meeting the clinicians and the patients where they are.
Yeah, one of the things about this work is, I've been a patient. And I'm certainly a clinician, and being able to sit in both seats. When you're a patient, you want to be able to know that the person in front of you who's going to care for you at least knows something about who you are and what's important to you. You want to ensure that they're not looking at you as just a knee or an ankle or another illness to treat, but you want them to know that you have a life, or you have children, or you have big dreams and goals, or you are more than your illness. So it's important for me not to kind of turn the computer down at 5 o'clock and punch in at 9 o'clock because people's lives depend on my ability to help to support our clinicians, my ability to help to find creative ways and creative solutions of helping us identify our own biases, our own hang-ups, and helping us stretch beyond who we are to accommodate and care for our patients in more appropriate ways. So it's really not just a job for me. It's a passion, and it's definitely aligned with the purpose of why I think I'm on this planet, is to help be a catalyst for better and safe care for patients and their own empowerment to get something as basic as health care that everyone should have access to live good, prosperous, and productive lives.
Jillian, thank you so much for joining us on the podcast. It's really been a fantastic conversation. Subscribe to the Providence College podcast in all the usual places, including iTunes, SoundCloud, Stitcher, Google Play, and our newest platform, Spotify. If you like what you hear, please review and share with others. Thanks for listening, and go Friars.